Hi, good afternoon, everyone. I'm Jennifer Peed. I'm the Managing Director at the AARP Center for Health Equity through Nursing at the AARP Public Policy Institute. So on behalf of AARP and the Center, I just want to welcome you. Thank you for joining us today for our webinar, Nurses Leading Change for Health Equity. A few housekeeping items before we get started. We are recording this webinar. It will become available on the Campaign for Action website shortly after the call ends. And we have reserved time for question and answer after the presentation. So feel free to use the chat feature to share your ideas, make comments, or ask questions. Or after the presentations, you can use your raise your hand function and we'll call on you. You can answer your question, ask your question live. And we just ask to ensure the best audio that you please keep your line on mute unless you're speaking. So let's get started. I'm delighted to introduce Dr. Deborah Stamps, Chief Equity through Nursing Advisor to the AARP Public Policy Institute. Deb will lead and facilitate our conversation today. So Deb, over to you. Welcome and thank you.
Thank you so much, Jennifer. Good afternoon, everyone. Thank you so much for taking the time out of your busy schedules today to join us for this webinar, Nurses Leading Change for Health Equity. Today, we're going to discuss and have amazing strategies and programs that were innovative from nurse leaders across the country that are focused on strengthening and diversifying the nursing workforce and enhancing health equity. We'll hear from a panel of experts representing 4 different projects that receive funding through the Health Equity and Nursing Innovations Fund, awarded by AARP and the Future of Nursing Campaign for Action, an initiative of AARP Foundation. AARP and the Robert Wood Johnson Foundation, we will hear from these programs, and I wanted to share a little bit that these programs are going to share their outcomes, their lessons learned, and really how are they continuing to work. Then we'll have time for some questions, and our hope is that these models will be catalysts for change in your various communities across the nation. So without further ado, we will begin with our first program from the Louisiana Action Coalition. I'd like to introduce you to Dr. Coletta Barrett and Dr. Lisa Hawthorne from the Louisiana Nurses Foundation. Thank you.
Thank you so much for having us. We're excited to share the work that we've been doing in Louisiana. My name is Dr. Lisa Hawthorne, and I represent Louisiana Action Coalition. I'm very fortunate to work with Dr. Coletta Barrett. She has been the instrumental person of this project and really moving it forward and making all things happen wonderful. So with the funds that we received, we coordinated with Dialogue on Race Louisiana and implemented a curriculum that was geared more toward nursing. So we now have, we finally refer to it as DORAN, and it's Dialogue on Race and Nursing. And at this point, I'd like to turn it over to Dr. Barrett to give more details about the program.
Thank you, Dr. Hawthorne. So the Louisiana Action Coalition serves as a conduit for engaging stakeholders in collaboration with the nursing community to promote health equity. And so the Dialogue on Race Nursing Project involves nurses in critical discussions to reflect on their personal beliefs about racism, fostering inclusivity within the workforce. By educating nurses to serve as facilitators for these conversations, the project aims to enhance culturally competent care and address the underlying aspects of racism that persist in healthcare systems. This initiative aligns with the ANA's goal and contributes to the broader effort, as you heard earlier, to dismantle structural racism and improve health equity in Louisiana. So in addition to educational sessions, the project includes an ongoing Train the Trainer series designed to empower nurses to facilitate these open dialogues on racism. This approach encourages self-reflection on personal biases and promotes a racially and ethnically diverse nursing workforce. By building a cadre of nurse facilitators, the program aims to sustain and perpetuate these critical conversations across nursing communities. Dialogue on Race Louisiana has a dedicated history of over 20 years of fostering race communications aimed at ending racism through education, action, and transformation. So the collaboration with the Louisiana Action Coalition was a natural extension in creating DORLA, our mission, enhancing communication among nurses and aligning with the Louisiana Action Coalition's initiative to strengthen and prepare diverse workforce. This project supports the advancement of recommendations from the National Academy of Medicine, Future of Nursing 2030. Specifically, it focuses on promoting nurse health and well-being and eliminating structural racism within the nursing profession. Given that nurses are the largest group of healthcare providers in Louisiana, we are pivotal in creating an anti-racist healthcare environment. Through the series that I'm going to take you through now, we aim to equip nurses with the tools and knowledge to lead the charge in fostering an inclusive and equitable health system. Together, we know that we can build a future for all Louisianians. The 6 dialogue sessions, session 1 about definitions and distinctions. It's important that we have a common language and common discussions around dialogue. Understanding the meaning of whiteness. This is important because whiteness sometimes can be in a chart, it's a word that's used that evokes great emotion. And so understanding white privilege that exists, people often have a truer appreciation for those who don't have white privilege. Understanding institutional racism, it's really important to know that we have to address the systems and the structures that force us to keep the disparities that exist. If you go to the next slide, session 4, these are, next slide, these are 2-hour conversations. And so session 4 talks about the struggle and transformation, looking at affirmative action, things that were put in place from a macro perspective that keep the race construct the way that it exists today. And then finally, with session 6, we talk about why race is important and all of the strategies that we've uncovered through the 5-6 sessions and what they mean. At the end, dinner and dialogue is where we come together, and this is where the facilitators eventually share their story, their conversation, because these are facilitated conversations. These are not debates. And so when you look at true facilitation, at the end is where we bring that all together. If you go to the next slide, I just want to highlight just a few of the promising practices. When Lisa said that we were going to create a curriculum, what we started out initially was to write that curriculum. And what we quickly understood was evidence-based practice tells us we build upon what we know exists and make it better. So we actually expanded the Dialogue on Race Original series for nursing. The Train the Trainer, meaning nurses can opt in to go through facilitator training at any time. Currently, we have 6 Dialogue on Race nurse facilitators, and it is, like I said, it's ongoing recruitment and training for future facilitators, and as I stated, that's an evergreen process. Implementing, we are in the middle of, we've just finished the very first, halfway through the first Dialogue on Race cohort that was launched in Baton Rouge. Our Shreveport launched, it did not launch on June the 11th. It's deferred 2 weeks for registration. And then the Lafayette series. What we learned, or the best practices, were this environment in what we call a virtual environment. Seems to be working better as opposed to requiring in-person conversation and dialogue. So this first Baton Rouge cohort was a hybrid, in-person and virtual. Evaluation and improvement on the initial design phase, meaning we took the Dialogue on Race original series that has been improving over the last 20 years, and we focused it with nursing, with a pre-survey, and we'll follow up at the end with a post-survey. Once all 3 regional hosted sessions have begun. And then using the dialogue approach, it is important to understand the difference about creating environment where nurses journey together and understand systems and structures that hinder the profession and providing quality care to patients, regardless of their appearance, color, and background. And using the dialogue approach has created such with our cohorts. If you go to the next slide, which is talking about lessons learned, we learned that there was no need to recreate a curriculum, but to build upon the evidence base. We learned that Dialogue on Race, a nonprofit organization, was the partner for us to work with to accomplish this. We also understood that 2 entities, the Louisiana Action Coalition and Dialogue on Race Louisiana, had to learn how to work together. We have a very different conversation and nomenclature and dialogue around healthcare and around nursing than what Dialogue on Race Louisiana did. So understanding how we work together and how nurses function gave us a greater appreciation and understanding for both organizations that set us up for perpetuating this into the future. A lesson learned was creating that shared vision and mission. And so coming up with a logo, with a Darla vision, with our commitment to continue this post our funding for the 2-year through the innovation grant was an important thing for us to learn. And then important, like I said, that securing the funding for to set us up for the future, that's signing a charter with Dialogue on Race Louisiana. We already have the funding for 2025, and so we will continue this program after we close out the grant period at the end of 24.
Thank you so much, Dr. Barrett. Excellent. Excellent work. The collaboration is amazing. That's helps with the sustainability plan, right? Awesome.
Absolutely.
Thank you. We'll have questions at the end. And so we're going to move on to our next set of speakers, Milani Brim and Megan Erskine, both from the Michigan Health Council.
Thanks, Deborah. Good afternoon, and thank you so much for the opportunity to talk about our project, Integrating Health Literacy and Implicit Bias Training and DEI Strategy Demonstration Project. Michigan Health Council is the primary co-lead for the Michigan Nursing Action Coalition. And kind of in full disclosure, when we started this grant, I was CEO of Michigan Health Council. I retired at the end of December, and Craig Donahue, the new CEO, was kind enough to let me wrap up this project with them. For the past few years, MHC has been working on health literacy and separately providing implicit bias training for health professionals as required for licensure and relicensure in Michigan. Through our continued efforts in both training programs, we recognize that there's an interaction between the two. And we now understand that health literacy and implicit bias training are interconnected and essential for achieving health equity. After conducting some research, we found that there was really very minimal literature out there addressing this intersection. So when this funding opportunity arose, we saw it as a perfect chance to develop a program focused on educating health professionals, most importantly with nursing, about this critical intersection. So for the description of our program, we launched a comprehensive health equity training program that explores the structural aspects of health literacy, implicit bias, and other health equity related elements at Catherine's Health Center, a federally qualified health center located in Grand Rapids, Michigan. And right now I'd like to ask Megan, who is Catherine's CEO, to maybe talk a little bit about why she was interested in being part of this project. Megan?
Yeah, hi everyone. I'm Megan. So I worked at two different federally qualified health centers, and I've undergone different health literacy trainings with our team members. And when Milani brought this to me, it just made perfect sense because I truly do not think that you can teach health literacy without addressing implicit bias as it relates to ethnicity, race, gender, sexuality, etc. So it just seemed like the perfect intersection to bring to our staff in an innovative way. Back to you, Milani.
Okay. So in designing our program, we looked for ways to also synchronize our efforts with Catherine's DEI strategy, which also was kind of at its beginning of its journey. So it was a great opportunity to try to weave this all together. Through the training, we equip staff with tools to identify and utilize effective, culturally appropriate educational materials and improve patient-provider interactions, which we know prompts a fairer healthcare system and helps to reduce health disparities. Additionally, kind of as a side project, we audited a sample of their patient education materials and provided feedback on their readability and accessibility. And the final component of our project, which we're now wrapping up, involves advocating for the state of Michigan to incorporate health literacy training as a means to fulfill the state's mandate for all health professionals to undergo implicit bias training. Next slide, please.
Okay.
So with regard to promising practices, there are three that we'd like to share. Based on training evaluations, offering training that explores the intersection between health literacy and implicit bias was certainly found to be valuable. It equips the healthcare team with knowledge and tangible skills that help reduce communication barriers and enhance health equity. We thought it was important to point out that organizations should adopt this as a standard of care, one that incorporates health literacy tools and techniques into everyday practice. Our health literacy toolbox includes a universal precautions approach, plain language learning, micro affirmations to build trust, clear and culturally competent resources, teach back, and skills to create a stigma-free environment. Now I'd like to turn this over to Megan, who's going to discuss an unanticipated promising practice that we believe shows great promise. Megan.
Yes. So as Milani said, the Michigan Health Council did a variety of implicit bias trainings over the summer, and then we did one all-staff health literacy intersected with implicit bias training last December. And in watching our team members, I could tell they were most excited about the role playing, any of the lessons from the health literacy toolbox that incorporated movement and interaction. And talking to our team members, those were also the most salient points that they remembered in being able to incorporate health literacy techniques into their everyday. And so I am a public health person, I'm a community health person, and I've also done improv comedy for 10 years. And I wish I was the first to bring this to market, but improv has already been used in the healthcare setting. It's been used in business settings. It's been proven to show better communication and collaboration. And because improv uses creativity and it uses movement, we know from the neuroscience perspective, people will remember those lessons more when they're using movement and creativity. So I said to Milani, do you mind if I do a pilot involving improv games with the health literacy toolkit with some of our team members to see if there's something that we can do in the future together? So next slide. So we did that. I had 7 team members who were frontline and a couple of administrators, and we took the health literacy toolkit and then we connected an improv game to every listen as it related to teach back, to plain language, to micro affirmations. We had a game designed to be the foundation to teaching the lesson. I worked in direct service healthcare and community healthcare and in public education. And for both of those professionals, they're on their feet, they're in front of students, they're in front of patients, and it's really hard to find time to train, especially if you're pulling nurses and providers out of clinic. And so I've been on a lifelong quest to figure out how to reinforce lessons, how to reinforce policies, how to reinforce standard operating procedures without pulling people out of clinic for 4 hours at a time. And so after the workshop, we realized that people really liked it. So our next stage is bringing these games to morning huddle, to team meetings, etc. So I think improv is a great reinforcement tool to teach health literacy, and it's very easy to incorporate into huddle and to team meetings. So this summer, I am going to go to all of our clinics, bring the improv lessons that are related to the health literacy and implicit bias training, and do just like 5-minute little games for people to be able to use, to remember, to bring into clinic. So I'm really excited that this sort of happened organically, because I think it's going to be a really neat tool for us. And then just the last thing, communication should tackle concerns regarding the time needed to implement the tools and techniques. I'm just going to say again that reinforcement in the clinical setting is really important. So even if you don't have 2 hours or 3 hours, finding those ways, those little nuggets to reinforce, make them fun, make lessons memorable, and most of all, practice, 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 so people feel comfortable employing those health literacy techniques like teach back, etc. So I think that's all I have, Melanie, if there's anything else you want to add.
No, I think that's it. Thanks, Megan.
Thank you both so much. I'm interested to learn more about improv. That's really innovative. You know, we hear about the poverty simulations and things like that. So that's wonderful. Looking forward to learning more. Now we're going to hear from Rita Ray and Lori Benson as they share about the work that they've been doing representing the Mississippi Coalition and the Nurses on Board Coalition. Thank you.
Thank you. Well, like our colleagues, it's really an honor, and we are so grateful to be a recipient of one of the Health Equity and Nursing Innovation Fund awards. So we're all learning from each other and excited to share with you today. I'm going to provide a little background and context about our project, and then Rita Ray will tell us more of the next steps and outcomes and lessons learned. So to begin with, if we could look at the next page, the description of our program. So when we look at the title of our project, Strengthening Nurses' Voices to Improve Health Equity, a community-based approach, I want to emphasize what we've heard earlier, the importance of collaboration. This is a community-based approach. So as part of our project, we were planning to develop and test the very first comprehensive tool to measure the value of nurses serving on boards, commissions, and appointments. And that data collected would examine how nurses who are serving on boards address the social determinants of health, leading changes in terms of structural racism, and also the support they receive serving in those roles. So our inaugural Value of Nurses on Board survey was shared with all of the action coalitions, the Nurses on Board's members organizations, affiliates, and strategic partners. All were invited to participate in this survey. We wanted to have a minimum of 500, excuse me. Our stretch goal was 1,000, and we had over 3,900 completed surveys. So we, as you can imagine, that gave us, we're grateful to all of you who participated and responded to the survey. This is nurses who are specifically currently serving on boards. And the rich data allows us to look at the findings and implications in order to guide our work forward. So in terms of the survey itself, we looked at the outcomes and then identified gaps. And we compared those to a concurrent project that we're working on called Supporting Underrepresented Nurses for Successful Board Service, which was funded by the American Nurses Foundation. So together, we're really able to fulfill the goal of our project, which is to increase health equity across the nation through an increased number and diversity of nurses serving on boards, commissions, and appointments. So we've been very excited to see this level of participation and collaboration. Our project also aligns with supporting the future of nursing. The foremost recommendations that were made in the National Academy of Medicine report, The Future of Nursing 2020 to 2030, charting a path to achieve health equity. Now, one of the other areas that we've identified is that there are opportunities by listening and learning from our collaborators and identifying where we can boost up the support. So Rita Ray is going to talk about this in just a moment. I also want to thank AONL and AMN Healthcare for also contributing so that we could fund this important survey that was the basis of our next steps. So at this moment now, I'm going to turn it over to my colleague, Rita Ray, who serves as our project lead representing the Mississippi Action Coalition, and the grant is being fulfilled in collaboration with those of us at NOBC and of course our wonderful Action Coalition colleagues.
Thank
Rita?
you, Kelly. Truly appreciate that. As it relates to the survey that you mentioned, we expected maybe 500, maybe 1,000, but we had over 3,000, which is absolutely great in my book. The top two subjects that just came back to us again and again when we looked at the surveys and the gaps that we found was that mentoring is crucial and training is necessary. With those two things in mind, we then went from that survey to the action coalitions. Each action coalition lead was asked, would you like to lead a town hall in your area, or would you like to participate with others in a town hall? In total, we had 5 town hall meetings. The individual ones was Louisiana, New York, and Indiana. The rest were all joined together, and we heard things different from various and sundry states. We had 3 questions which we addressed. They were, where do we need to bolster nurses? Looking at boards. The top 3 things that came in was on hospital boards, rural areas, government and legislative related. The second question was, where are nurses currently impacting health equity through their communities? And the answers came back through their community, the community boards, especially the ones related to health, and then as well as the United Way, which was a surprise to me, and schools. The third one is, where are voices missing? The top 3 that came back was hospital boards, community boards, and pharma, big pharma, and insurance. So the town halls were exceedingly helpful in helping us further delineate where we were with these 3 questions. Our next steps will be to develop and disseminate the education, planning, tools, resources that the nurses say that they need to better be able to equip them to serve on community boards or any board for that matter. So that's where we are in the phase of our project.
Thank you both so much. Excellent work. And would love to learn more about the trainings that will help those that are interested to serve in our discussion. Thank you. Okay, so next on our agenda is that we will hear from Kelly Nellis from the Wisconsin Action Coalition and the Wisconsin Center for Nursing.
Thanks, Deborah. I appreciate that. And I just really do love hearing about all these projects because each of us saw a unique opportunity and a unique challenge. And I really feel strongly that the innovation awards that were part of this health equity initiative from AARP really helped us kind of be able to move a lot of this work forward. So thank you so much for that. Our project's a little bit different in that it builds off of, whoops, that's not me. It's not me at all. There you go. Our project has really been, this this innovation award really allowed us to move to the next level of focused health equity. And what I mean by that is, with one of the tenets or one of the missions of this innovation award being focused on looking at structural barriers, that was really a terrific opportunity. And so as I begin to explain this to you, I want to just give you a short snapshot of what kind of led up to this, because I think you'll be able to, this will make more sense to you. But shortly after the onset of the pandemic, about 3 months into the COVID-19 pandemic, it became apparent in our state, like in many states, that public health emergencies magnify the negative health consequences for people.
Thank you.
And that vulnerability is called out very strongly in the Future of Nursing report. And one of the things that we were able to do in our work leading up to this particular grant was we took a different approach. We took an approach where we identified who were the most at-risk populations in Wisconsin, and who were those grassroots organizations that were really connected to those populations that could provide us with a framework of where they were receiving care. It allowed us to do what we call care mapping, and through care mapping, we were able to connect those nurses that were in organizations and healthcare systems that were going to be charged with addressing the needs of vulnerable populations. From there, we recognized what the Future of Nursing also describes, is that 78% of nurses have little or no emergency preparedness education. And in Wisconsin, our nursing workforce surveys echoed that and emphasized that of the 80% or so nurses who did have emergency preparedness education, it was employer specific. So being able to look at this with a broader lens that was focused on health equity, we identified that a nursing workforce better prepared to ensure public health initiatives are supported, vulnerable populations are identified, and that nurses have the tools and resources to be able to offer strategies that would reduce risk and contributed positively towards improving health outcomes. And so that work really led up to this particular outcomes for these grants. So in this particular innovation award, we were looking at, all right, we've kind of got those nuts and bolts pieces in place. Now what do we do as far as strengthening Wisconsin's nursing workforce during a public health emergency? And we had identified through our listening sessions and through our focus groups and through our interactions with multiple stakeholders that for the most part, nurses in those frontline positions, and what we mean by frontline positions is we're talking about nurses who are in roles where they touch the patient as they move back into the community, or they're touching the patient in the community. So they're the nurses who are involved in care coordination and case management and care transitions. They're involved in chronic care management. They're involved in home health. They are present across the continuum, yet we learned they had no connection to the community-based initiatives that were being put in place during the COVID-19 pandemic. So one of the first aims of this project when we were looking at structural issues was to identify potential Department of Health Services partners that we could collaborate with to create a pathway for communication and connection of these frontline clinical nurses who are working with these at-risk populations to be able to be connected in and communicated to as a part of the emergency response initiatives that were going on in the state. This award also allowed us to provide 175 Nurses Respond Now priority training scholarships. And the Nurses Respond Now priority training is something that we've created. It's not a replication of existing emergency preparedness education, but instead is focused on equity and teaching nurses how to better understand vulnerability and be able to address social determinants of health, because many of those practicing nurses, as you know, never, unless they were in a public health role or public health course or community health course, never had access to these components of education that we've identified are essential. So in our state, we learned that we have 7 HERC regions, and that stands for Healthcare Emergency Resource Consortiums or coalitions. And these regions each have a coordinator who head up all of the emergency responses. They coordinate all the emergency responses of all the health systems occurring in that region. And so in this, with this award, we were able to make sure that these scholarships were distributed evenly to nurses in all 7 of those regions, so that we were able to build out the workforce in those across the state. And then the third aim of this project was recognizing that we really needed to establish an emergency preparedness advisory committee. Key experts and stakeholders who are working closely that could work with us and help us to focus on strategies we could use to strengthen Wisconsin's nursing workforce, to make sure that we're including community-based preparedness in nursing practice. Next slide. So I will say that, well, I'll get to that in a second, I guess. So the lessons learned. We learned very quickly, like most of you, it's not that we didn't know it, but it became visible very quickly that the events of the pandemic left our public health nurse colleagues feeling devalued, defunded, and isolated. And we learned a great deal about the extent of how that was impacting them and how the public health departments had changed because of the number of open positions in the public health employment, just the lack of resources because of funding, and the fact that the intensity of the work was changing day by day and everything was new and different. And for the first time ever, many were having to deal with disinformation on such a dramatic level that, as you know, that caused a lot of chaos in a lot of, especially for at-risk and vulnerable populations. So we spent a lot of time, we recognized that this was important for us to connect with them and also be able to communicate for them that they have specialized knowledge and leadership that they provide. We identified that there was strength in fostering our partnership with them. And in exchange, I think they've come to see us as somewhat of a champion for them. I know we've been able to be play a significant role in several resolutions that have been developed for the Governor's Task Force on Public Health Nursing. So that was an unexpected outcome, I guess, that came out of that, but we're pretty happy about that. The second lesson learned is what a lot of you have said already. Finding the right partner takes time, and it took a lot of time. And the reason why it took a lot of time is you learned really quickly that siloing is everywhere, right? Everyone does their thing, but that doesn't mean they're always collaborating or working together. So while we had a lot of support for this initiative, it took a lot of stopping and starting and trying again to find those right partners that we could connect with. It also required us to learn both the federal and the state required emergency responses, including the funding streams, as well as the language that they use. So I kind of equate this like when when you're working with health insurance, for example, there's a whole language that goes with that. Well, there's a whole language that goes with emergency preparedness and homeland security within the context of the Department of Health Services. And then thirdly, we learned that, and confirmed really, that frontline clinical nurses have been left out of the response. That while the HERC coordinators had good relationships with the public health nurses and some of the emergency department nurses, they had never really recognized that there were other nurses working across the continuum that they could also partner with to strengthen a community-based response and overall improve health outcomes. So a couple of things that kind of stood out for us. All healthcare organizations have an emergency manager that connects with the HERCs and then communicates back to the health system. But we learned that communication generally goes up to the C-suite, but does not trickle down or get down to those frontline touchpoint nurses. We learned that there is a limited relationship between the public health nurses, the public health departments, and the frontline clinical nurses. They didn't really know a lot about each other's roles. They knew they were there, but they had not really developed a way of collaborating or communicating to share essential information. Also, we had thought that, like in every state, there is a volunteer registry that nurses and other health professionals can be a part of. And we thought this would be a tremendous resource for us to being able to access nurses pretty quickly and be able to make some significant changes. And what we learned, in fact, was, while this is a tool, it is, for our purposes, it really was very static and somewhat limited. And that, in fact, if we could teach nurses how to connect with the HERC coordinators, that is where they would have immediate access to not only information, but also to
Please mute your line if you're not speaking. Thank you.
Thanks. But also to trainings and services that were becoming available. Next slide. Whoops, was that my last one?
Aiden's getting it back up, I think.
Okay, thanks. I think I got a promising practice there somewhere or something. There we go. All right. So what did we learn out of all of this? We learned that once we connected with the Office of Emergency Preparedness and Homeland Security, that within that office, the best place for nurses to connect with these community-based public health emergency initiatives is with the statewide and regional HERC coordinators. They're really the ones who know who coordinate everything, and they're best at, they're really open and really interested in establishing collaborative and supportive relationships. And we continue to be in dialogue with them in creating pathways for these connections to continue to occur. So for example, when we're looking ahead at sustainability, we will be meeting with them. We'll be having an annual conference, the first one, actually in conjunction with our WCN Diversity and Equity annual meeting or annual conference. We will be bringing together the HERC coordinators, the public health nurses, and the Nurses Respond Now scholarship graduates to finally meet each other for the first time. And we're going to be able to connect them by region so that they can make sure that they know how to communicate with the HERC coordinator. They can get their questions answered on how to make sure they're registered for the volunteer database, how they can access the community health assessments that the public health nurses are charged with doing and that they didn't really know about, because they have identified that they don't know a lot about the populations that they're working with, as far as what they're most likely to experience and what the social determinants are in those communities. I also want to point out that with a 99% completion rate, nurses report that the Nurses Respond Now priority training meets the practice recommendations that build on recommendation number 8 of the Future of Nursing report. And this is consistent since the beginning, and we continue to develop and update and vet and monitor and do all those good things. And we're really feeling that now that one of the sustainability pieces that we can move to putting into place is using this as foundational content in piloting what we an EPR certificate. So like the CPR certificate, where we expect all nurses to know basic CPR, the EPR certificate would give us a mechanism to identify nurses that know these basic community public health initiatives and who are able to address social determinants. And then finally, the formalization of an emergency preparedness advisory group that's committed to including vulnerability as a construct. This we feel is essential in guiding nurses' integration of emergency preparedness into their practices. And we want to be able to provide them with a reliable supporter, if you will, of being able to develop their practices out, because for many of them who've been in practice for a number of years, they will be appreciative of having that kind of support. So that's this project in a snapshot. We're excited that it is has allowed us to accomplish so much in a short period of time. And I would just say that if you're interested in this program, right now it's been focused and piloted in the state of Wisconsin, but with the most recent addition of the Nurses Respond Now priority training, it has been developed in a way that it could be used in every state for anyone who's interested. So if you want to just click on my bio, that will take you right to the Nurses Respond Now priority training page, and you can get more information. So thanks.
Excellent. Thank you so much. Wow, we've heard so much collaboration and alignment with state, national organizations. Just learned so much from all of you today. This is wonderful. I think we'll start out with taking some questions. I'll start in the chat at the beginning. Just want to remind all of our attendees that each of our presenters' bios can be found at the Campaign for Action webinar, Nurses Leading Change for Health Equity. That site is set up and each speaker's bio is there. Again, thank you for all attending. First question is to the Louisiana team, and offering a virtual delivery is this open to outside of Louisiana nurses for your program?
It will be our this year finishing out our grant. It's from across the state of Louisiana. But there's discussion with the advisory group that because in our training for facilitators and in other dialogues sessions that are not just in nursing, there are people from all over the United States that are entering into the conversation and being trained as facilitators. So there's nothing that says the geographic boundary. It's an opportunity, let's put it that way.
Awesome. Thank you. And how many participants have you had across Louisiana to date?
Well, right now, the Baton Rouge cohort was the first one. We limit participants to 15. If you have more than 15 in a dialogue discussion, it becomes, it's just not conducive to the aspects of what you want to do with a true dialogue. And so we limit it 15. And so we have 13 in the Baton Rouge cohort.
Wonderful. Thank you so much. Thank you. This question or statement is actually towards the Michigan team that just says, way to make learning fun and working it in to the limited time that healthcare professionals have in their day using the improv. That's wonderful, wonderful, wonderful. And another question around the improv is, will the improv be age specific?
I haven't thought that far. It could be. I think because the health literacy toolbox is so specific about all of the skills that you're learning, I think the improv game is really designed to be the skill that makes the health literacy toolbox skill work. And I think improv, anyone can do improv. All of you are creatives. Everyone who's a nurse is a creative. Anyone in public health is a creative, because we solve problems all the time. And that's why I try to talk about improv from that perspective of it's just a problem solving skill. The other thing I didn't mention about improv that I really like is when we're talking about equity and we're talking about implicit bias, improv challenges hierarchy, because you have to let go of your ego and you have to suspend judgment. And one of the games that we played was talking about how hierarchy shows up in the clinical setting between providers, patients, and support staff. So I think it doesn't need to be age specific. I think it's available to everyone, but that's a great question, and I'll certainly consider it in the future. Thank you.
Awesome. Thank you. Thank you. Thank you. And I think this question was answered, but the health literacy toolbox, is that available for sharing?
So that is a great question. So right now, the toolbox is the way we present it in the curriculum and the training program. But I think I posted in there, it sounds like creating a physical toolbox that people can use would be helpful. So we'll be working on that. But right now, it is the way we frame all of the tools that we teach in the program.
That's great. Thank you.
So, and one thing I just add kind of builds off of what Megan said about the kind of the age specific, but kind of not really, is that really all of the focus of our health literacy training is about educating providers how to be effective communicators. And we use the hashtag "It's always on us." We're not trying to fix patients. We're trying to develop the skill sets and the tools and techniques to help us as providers be more effective in our interactions with patients.
Okay, great. Thank you. And that goes back to incorporating, have you incorporated in your toolbox or your tools the Campaign for Action's Health Equity Toolkit? Is that one of the tools that you've used?
Yeah, so we really are building our own toolkit, toolbox. We use resources from CDC, AARP, and as well as the Health Equity Toolkit. So it's really pulling kind of best practices from all of those and kind of making them our own.
Great. Awesome. Thank you. Okay. Let's see. This is geared towards NOBC and the Mississippi Action Coalition. Is the training available for those interested on being on a board? Is that available widespread or only for specific individuals?
It shall be widespread. That's one of the resources and/or tools that we will have not only develop but disseminated about how to be on a board.
Awesome. Thank you. Thank you. And was there any feedback that you received from the town hall meetings that helped to realign or enhance the work that you're doing?
It supplemented what we're doing. As I stated at the very beginning of my presentation, after the survey was done, we knew that mentoring was exceedingly important. We knew that training was just necessary. It helped flesh out the types of training that's needed, and that will help folks be on board and to address any racism associated therein.
Awesome. Wonderful. Thank you. Thank you. Thank you. There's a question to the Wisconsin team. Are you working with the AARP state office?
That was Jen. I just was curious with the piece on, you were talking about partners, and You know, AARP is a bit involved in the space of emergency preparedness, so I was just curious.
I appreciate that question, Jen, because I think that we have everything set, if you know what I mean, to be able to expand beyond our state. And it might be time for us to just have a really good conversation about that because, and Debbie, when you mentioned the health equity toolkit, you know, the fact that we all had that available to us, that was so nice to be able to just pull from that and integrate that in because I actually use that all the time, and it's integrated and embedded throughout the Nurses Respond Now training, as are the public health initiatives that we learned nurses need to really be able to support. Clinical nurses didn't always see that they had a relationship with public health. And so that was one of the teaching principles within that curriculum, and being able to help them see and understand how they can collaborate and support public health initiatives. And on the flip side, being able to talk with our public health nurse colleagues on the unique roles that some of these frontline clinical nurses have, you know, strengthening their understanding of transitional care management, strengthening their understanding of chronic care management, the opportunities that nurses across the continuum also have for addressing social determinants of health and screening for social need. I don't know if you all know this. This is a really simple takeaway, but United Way 211 is throughout the United States and Canada, right? Most of the clinical nurses did not know that. They didn't have awareness. The public health nurses were used to working with it, but the clinical nurses did not. I mean, they were grateful to get the information. How did I not know this? You know, but there's just really simple things like that that seem like low-hanging fruit, but they make a huge difference. And I think that's a really simple example of, well, it's not the biggest structural barrier to addressing social determinants of health. It is a barrier, and now we've been able to correct it the same way in being able to understand communication pathways and who gets the information and who doesn't, and how resources are distributed and all those pieces that go into it. So I guess to circle back to what you said, Jen, yeah, I think we're ready for a bigger conversation.
Great.
So
great. I'll follow up with my colleagues and see what we can do.
Awesome.
All right,
Thank you so much. We have a hand raised. Kim?
I'm so sorry. That was an error. I'm trying to remove it. I apologize.
Hi, Kim.
Hi there.
I'm sorry. Thank you.
No
It's
worries.
fine.
No worries. Awesome. To our panelists, is there anything else you'd like to share with the attendees today?
So I just want to say a comment to Louisiana. First of all, I love your acronyms. They're easy to remember, and I think they'd be really attractive to nurses, but I just love how you took this on. You know, it's easy to not do, right? And you took this on in such a, and what stood out for me and what you had to say was the focus that you took on facilitation, so that people could do their own work, right? That it's not a debate, it's a facilitation, and people can have an opportunity for process. And Megan, you cracked me up with the improv, because I do a lot of work with equity-minded team-based care. And so I sit here and go, that would be like amazing to be able to do that.
We'll come over to Wisconsin. We'll take a boat across.
Yeah, we're not that far away. We'll connect up. That's good. Anyway, I can't even imagine, Rita and Lori, when you're hoping for 500 responses and these thousands keep rolling in. I mean, you must have been going, I know this is a good problem to have to process this, but holy smokes, how are we going to, get this all done? But the richness of what you've been able to glean from that, I mean, we all can really benefit from that. So really, thank you, everyone. I've learned so much today.
So in that light, I would like to share that as we came together about a week ago and listened to what each of us were doing with regard to a specific project, I was struck by the impact of being grantees. All of us are grantees under one umbrella. I think that is so powerful that when we can talk about Health Equity Innovation Fund grantees, it gives us credibility and it elevates the conversation. So all of us have cared deeply about many of these areas, and we're working on them in our own areas at the local level, at the state level, and the national level. But I've absolutely observed the power, the positive power of having it under an umbrella of 15 awardees and really looking at what the collective impact is. And without this catalyst, it would have been, Kelly, you just brought up some of those challenges to be able to fund it, to be able to bring people together. So I don't want to underestimate the importance of this being an innovation clearly to improve health equity. And we're making a difference already with everybody helping. There's a place for everyone here to make an impact.
Well, and to dovetail off of that, to have the Future of Nursing report, I know how much work that had to have been to put that report together, but to be able to draw on that so that you were able to feel confident that we were all rowing in the same direction, right? That you weren't working in isolation, that you knew that this was the initiatives that the profession valued and identified and was taking forward. And that lifted really, for me anyway, it really lifted kind of a burden because it freed me up to think about how can I translate this into practice? How can I make sure this gets applied? How can I make sure that nurses know about the Future of Nursing report? Because many clinical nurses don't know about the Future of Nursing report. It's not the space they're in. And so being able to promote nurses on board and being able to talk about, those important conversations, I don't know, thank you everybody, because it really is helpful to our individual work.
Let me add something, please, to we asked for innovative ideas from the participants of the town halls, and many were given, but 3 that surfaced were, we all need to develop an elevator speech about the value of nurses on boards. So when we're talking about nurses on boards, just a very simple elevator speech about why we should be there. The second piece there's still reiteration about things that they need to serve on a board. And over again, it came back to, we need to know more about finances and how to read the financial statements that are there. What do they mean? How do they impact us? Then that third piece there was to utilize Nurses Day in a different way. Now we have a whole year long to take a look at that in 2025, but just educate whomever we're educating about our power of speech there, about why a nurse on board, identifying any barriers that are there and challenging people to help us bridge that gap.
Powerful. And you all are still innovating. This is wonderful, and still making an amazing impact. I could not sum up the session any better than what you all have just stated. And when I think about, as I was listening to each of you, you're all making impacts in your community. And the hope is that your impact will continue to impact the nation. That's the goal, or even global, right? Let's go out beyond. And you're all going to do that. This work that you all have shared, your work is highly replicatable. And we just need to think about the collaborations, the innovative ways to partner, to fund work like this, because the ultimate impact and outcome is improvement in access for every individual to have access to health equity, right? We'll know that when everyone, doesn't matter where you live, what you look like, but everyone will have high quality healthcare. And this is just really exciting to hear this work, and just to hear the continued dialogue and how you can continue to strengthen the work that you've already started, just from the colleagues on the line today. So thank you all so much.
Thank you.
Yeah, make sure you read the chat. All of our folks listening in are also sending their regards to you for these amazing projects. I know at AARP, we're particularly proud of you all. Thank you for sharing with us today. You're very inspiring, you know, from a grants perspective. I'm like social worker behind the scenes, crunching the number, getting the awards out, but you guys are doing the work and it's amazing. So being able to hear from you today and see the lives you're changing gives me chills. So thank you.
Thank you all so much. Keep up the great work, and we look forward to continued impact and outcomes. Thank you.